My name is Martha. I am the current TMA Alliance president. And as Jennifer stated earlier, we are in Austin. We're going to be filming our installation speeches today. So Jennifer's here with me. I just want to thank you guys for showing up and coming. We have such a great speaker today. I am really excited about Dr. Gulbronson. She has received her bachelor's from Rice University. She did her undergrad schools at UT Houston Medical School, and then she did a residency at UT San Antonio. But then she moved on to North Carolina, where she did her fellowship in development behavioral pediatrics. Currently, she is the medical director of development medical services at Driscoll Children's Hospital. And that's where I've gotten to know her. And she is a fabulous doctor as well as a friend. And so I'm so happy that she's here with us today. This topic is so important for timely fashion right now. And unfortunately, it is really needed. So thank you, Dr. Gulbronson, for sharing your lunch hour with us. And I'll let you take it over.
All right. Well, certainly thank you for the invitation. And I know Martha's husband, Dr. Vijay, because I met him when I was in San Antonio. So I've known him for many, many years. All right. So let me move on. Let me see, make sure my... Okay. All right. So the topic will be pandemic impact on mental health in our youth and adolescents. And because of my background, I'm going to talk about it from a developmental peds perspective, but also talking about the role of the pediatrician and kind of how that can be of help with the families and providing some guidance. Overall, I'll talk about, yes, the mental health impact, because it's certainly there's statistics we'll go over that were pre-pandemic, because there was quite surprising in some areas to see that a lot of things were already on the rise. And then with the coming of the pandemic, it got worse. Okay. So there are pre-existing conditions that clearly were exacerbated in some of the students and some of the patients that I follow for care. And then we'll definitely go over some of those statistics as well. So NAMI is a very good grassroots organization. It has this quite impressive slide that pretty much paints the picture of what mental health looks like across the US in general. You will see that it's about 1 out of 5 children that will experience a mental health condition in a given year. So that's really a high prevalence rate. 1 in 5 is about 20% of all the kids coming in to see that general pediatrician. And I stress that to the residents, particularly those graduates that are going on to pediatrics for general ped care. Half of those kids will not be receiving treatment. So there's a lot of barriers to care. And certainly with the coming of the pandemic, it made things worse when a lot of things shut down. Okay. And then it's important to keep in mind that over a lifetime, this was an impressive statistics, is that half of all the lifetime cases of mental health start to begin by age 14. So a lot of families will drop off that well child care exam once they're younger, but it's really then important to maintain that well child exam and go into that well adolescent examination, so that making sure that the pediatrician is maintaining that mental health surveillance that's ongoing, because that was quite impressive. We need to get a handle on that. So if we look at this is older data, and the question.
Excuse me, your slides aren't advancing, at least on my screen.
Oh,
I'm only seeing, yeah.
Okay.
I'm on the first slide. If you're,
okay.
I wasn't sure.
It's going up, changed on mine. It didn't show on yours. Okay. Let me see.
Maybe put it in slideshow mode.
It is in the slideshow mode. Let me see.
Are you hooked up to more than one monitor?
Yes, I am, and I can't set it on the other. Whoops.
Oh, yeah. I think you're just sharing the. Let's see.
So let's see.
There you go.
Yep.
You see it?
Yep.
Okay.
Yes.
All right.
Sorry for the interruption.
Oh, that's fine. No, let me know, because I'm not always the savviest with this technology stuff. Okay. All right. So we'll continue. Okay. So this one was from 2016 data, and it's a national survey. It's like 60,000 some parents that are asked questions on here, and they were able to break it down into what the general prevalence rates are at right now, or at least pre-pandemic. So about 7% had anxiety problems, the generic behavior conduct problems with another 7%, 3.2% had depression. But what they found out is the older age group you go into, if you go into adolescence, and the poorer the child's health is, so if they've got more chronic health issues, if the parent has their own share of mental health problems, all the numbers start to go up. And so there's a lot of treatment gaps. So the data then, if you look at the data, you can see, boom, clear rise as you get into some of those adolescent years, that you start to have much higher prevalence rates, okay? When the national survey was updated, they lumped together, they did a little differently. They lumped together the 2018, 2019 data, and then they lumped everything together. So they asked, you know, does your child have a mental, emotional, developmental, behavioral problem? And it was 22% prevalence rate. So again, it's like that 1 in 5 has some kind of issue going on. They did have very specific questions looking only at ADHD prevalence, which put it at an 8.7%. And then the prevalence of your child having a current diagnosis of autism was that 2.9%, okay? All right. And then looking at data pre-pandemic, if you look at and you follow timelines for suicide rates, this is where I was surprised. They were already clearly on the rise. I mean, there was big jumps looking at this time frame from 99 to 2018. There was a 35% jump in rates just looking specifically in the 10 to 14-year-old groups. If you looked at other teen data, that's where it really skyrocketed. In the older teens, it jumped as high as 56% during a 10-year span. So that was seen there. And then again, other rises that are seen in older data. Of course, if you're going to look at it post-pandemic, oh yeah, it all went up, okay? And one of the studies, this study was done in Texas, and they looked at, this one, I jumped ahead. So here, we're looking at what exactly happened. And those of you involved with the school systems, you see with the school closures, all the stay-at-home orders, there was increase in the feelings of social isolation. You had your loss of connections with other kids, loneliness, and a heightened anxiety. And when surveys were going out and the CDC was looking at this data, I mean, you surveyed college students in high schools, and more than half of them were all worried about their own mental health issues. A quarter of them had already had some suicide ideation, and about 5% of those surveyed at the time had already reported attempting it themselves, okay? So what does the impact look like? So there's a lot of general mood disturbances going on, and sometimes it's hard to put your finger on it because it could be anxiety, it could be depression. You see an increased sadness, this lability in mood. You're happy one moment, things are going fine, you're crying, you're having some cognitive dysfunction with difficulties concentrating and attention issues. And then the changes that have gone on to the activities, I mean, stuff you like to do, you no longer like to do. Unexpected headaches with a lot of somatic complaints, and changes in eating habits. It could go either way, eating not enough, eating less, okay? And when they looked at, this is the one study that was done here in Texas in a big metropolitan area, they routinely have a suicide risk screen that is done when they present to the emergency department for whatever complaint it may be. And so they collected data looking at 11 to 21-year-olds, and they compared data from 2019 to 2020. And clearly the whole suicide ideation rates had gone up about 1.5 times when you looked at those months from 2019 compared to the ones same months in 2020. So it was a definite increase. And they didn't see it split along the lines of gender nor of racial ethnicity. It was increased across the board. And then it turns out, and this caught my eye, because the chief complaint for those kids and young adults showing up into the ER, look, the clear majority weren't complaining there that they had suicide ideation. They had to get it out of them, because it was only 3.5% that were forthcoming with those very concerns, okay? All right. What's the impact on the special needs students? So this is where I appreciate more of the challenges, because this is my population of kids. As a developmental peds, I am working with the kids that have intellectual disabilities, that have ADHD, autism. These are the kids I follow. And so there's been a lot of disruption to meeting their educational needs. And even though the feds declared that there's no waivers and they're supposed to do all of the evaluations under timeliness, all of the services are supposed to be provided, honestly, they weren't. Okay. I've had kids that were from the Brownsville area that when things shut down, I mean, they shut down. They couldn't access any of their developmental therapies. They weren't being offered Zoom sessions. I think here in the Corpus area, things opened up a little bit more, but then I have other patients that I see from Laredo, same thing, is they shut it down. So, and the parents say, oh, it's because of COVID, and they go with that. But yet, you know, we know that the feds didn't give the school districts a waiver. So they really have to get creative. And I had to let families know that some of these school districts are offering additional Zoom sessions. As difficult sometimes it is to engage these kids, I mean, sometimes we feel something is better than nothing to kind of keep tabs of what's going on with those special needs that they may have. So what can parents do to offset some of the stress that's just happening? Because even my own two adolescents are complaining. I mean, they do hybrid program, they're still in athletics and they got to go on the school campus, but they struggle. One of them in particular does struggle with having to do those Zoom sessions for instructions. He does much better in person. And in fact, now that they are going to do away with the hybrid schedule, he's going to go back in person. So what parents can do is certainly remain calm. You want to deal with the situation wisely, kind of follow what's going on in your particular school district. I try to answer questions. I'm not the infectious disease specialist, but I'll try and answer questions to the best of my ability. But at least I know some resources I can go look at and answer positive facts and figures that I can provide. Because I do sometimes tell them, take a break from the social media, because you hear the news and it's, oh my gosh, the next variant and all this uproar. And when I talk to, we hear talks from our infectious disease specialists, it's a very different take, you know, so you want to make sure it's not so exaggerated in the media, and it just kind of, it's this fear mongering that does go on to some degree there. Reassure safety in the home. So, you know, those are the things that, hey, we here, luckily we've all had opportunity to get vaccinated, part of the healthcare, I've been able to do that. So it alleviates some of that stress and worry. And then maintaining other activities. So we've had families totally secluded that are so fearful of going anywhere that they don't. And that can be a whole lot more stressful with the ongoing dynamics. And as much as possible, keeping a schedule too. I'm gonna scroll this down. All right. And I found some really nice suggestions, guidelines. These are parent tips that are sponsored through the WHO organization. I had linked on some of these and looked at some nice strategies that they were offering on how to cope with stress, anxiety, talking about media information and managing adversities, and some nice flyers for public announcements and encouraging parents that are, again, willing to talk to the youngsters, because sometimes they think the worst. So it's kind of alleviating some of that fear and misunderstanding of some of the information that circulates out in just the regular media. So the role of pediatrician really becomes important for families. There's a lot of overlap among the specialists. Like, I'm a developmental ped, sometimes neurology is involved, sometimes it's psychiatry that's going to be involved. Sometimes it's a mental health provider, like a licensed clinical social worker or a licensed professional counselor. And sometimes families don't know the difference between who does what. So hopefully it's the general pediatrician as the medical home that will guide that family and initiate an appropriate referral. I believe in getting kids to the right place the first time around and not just throwing them out there and we're going to send you here, here, here. No, what's the referral concern? Whose specialty is going to best address the concerns that that family may have, and or the question, the referral question that pediatrician may have as well. Okay, so we'll talk about common signs of distress. So as a parent, you know, what are you looking for? This was also very helpful when they were back in school, and hopefully things start to then, you know, normalize as best they can, because sometimes teachers, really sharp teachers, pick up on these things, you know, the mood changes that go on in the children. If there's truancy problems going on, that kid looks more disheveled and unkempt. They can notice the changes, you know, and sometimes parents are busy with work, busy with life, and they're not, you know, they don't see the kids on a, and note that, but the teachers are always good at picking up some things up, you know. So they will sometimes initiate those parent teacher conferences that bring it to the parents' attention. Other things would be the substance abuse issues that are more likely a concern in the older kids, you know, how much disciplinary actions are happening. Other students may bring up concerns about it. You know, sometimes they'll disclose, and it's not about being a snitch about it, but it's really concern that somebody's talking about hurting themselves. So they're going to disclose that to a teacher or the counselor at school, and hopefully then that adolescent will get the help they need. And then changes in sleep habit. Are they always, you know, and again, you know, you have your typical teenage sleep hygiene issues, but these would be either extraordinarily increased or decreased and always tired that would bring up some concern. Academic indicators, so important as well. And again, this is what I miss from not having these kids in schools, because the teachers also are good. If there's a deterioration in the quality of work, I know my adolescent son who's ADHD, he wasn't telling me he wasn't taking his meds, okay? And the teachers will email, is there anything different in the house? You know, he's starting to miss his assignment. So then I got the heads up and I had to confront him about it, and he disclosed he actually was having some complaints and side effects of it. So we needed to address that. Repeated absences from class or lab, even though they need to, even they're online and they have asynchronous learning, they still need to put those hours. So I know the school districts are hammering down on these hours of attendance. And for those kids that are missing this instruction, even online, they are trying to track them down and make sure that they make up that work, okay? Kids that are always asking for a break, you know, can I turn this in tomorrow? I'm sorry, I'm late, you know, those kinds of things. These are all can be academic indicators that something's up. And that's important. I like this slide because it's the tip of the iceberg, but having a poor academic performance can certainly reflect something's up, okay? Any of these conditions could be what's just, you know, on the surface. And again, it's digging in and figuring out what's going on. So if the teachers can bring that to the attention of families, that's great, because then they can seek out the care they may need, you know, from their medical provider as well. So COVID certainly, you know, when it came, there's a lot of new anxiety going on, depression that got triggered, but it also exacerbated existing mental health problems. So this one slide, though, it does talk a lot more about the adults. I mean, even before COVID, they were saying 19% of adults were experiencing a mental health illness. Well, what was the increase? Well, now it was up by 1.5 million more people having issues. So it's, I mean, it's gone up, okay? And unfortunately, access to care is still an issue, because in this case with the youth, 1 in 3 are not getting the treatment they need, okay? So there's a lot of concern there. All right. Okay, now I'm going to switch gears and I'm going to talk about the 3 most common of conditions or diagnoses that we deal with, okay? The disruptive behaviors, these are these kids, man, that you're pulling your hair, and I tell the residents, this is what gives the parents early gray hair, okay? It is those kids that we typically think of that have ADHD type symptoms. Maybe we haven't defined that yet, but they have a lot of what we call externalizing behaviors, along with that oppositional defiance and those rule breaking behaviors. And these disruptive behavior patterns is what accounts already more than half of the referrals to mental health services. So it takes a big chunk of, you know, referring these kiddos to a licensed professional counselor, and mostly for behavioral therapy. And there's one study that was done in the Journal of Adolescent Psychiatry found that ODD was the most significant predictor for caregiver strain. So it's still an issue. And we've seen an increased number of referrals for a lot of these disruptive behavior patterns in our more recent batch of referrals that are coming into our clinic. So what is it looking like? Let me see if I can shrink this. Okay. All right. So it's examples would be, you know, the typical oppositional defiance stuff. They're refusing to comply with teacher or parent directives. They always challenge authority. They know how to work those buttons and get a rise out of the parent. They can be loud, distracting, overtly hostile defiance. And some kids start to exhibit more serious rule-breaking behaviors. So these are the ones we worry that, man, if we don't curb that, they're going to be heading down a juvie. So these are that worrisome behaviors. So just more pictures of those disruptive behavior patterns. So what works for these kiddos? So this is where Texas in general has fallen short, and really needs to revamp even some of the kinds of behavioral therapies that are offered in managing these disruptive behaviors. Oftentimes our families are being referred for play-based therapy, but turns out that's not evidence-based to really be effective. Instead, what they found is parent behavior therapy, meaning there has to be a parent training component, has the strongest evidence that it's the most effective of treatment. And that's whether it's done in a group setting or individual parent behavior therapy, those were found to be the most effective, okay? And getting the right treatment early is going to be key. So this is what the research has shown. So there are some good books that I share with families whose child tends to be very oppositional and defiant. The Kasdan method is one of them. He's a psychologist out of the Yale Child Study Center that manages conduct disorder kids. Russell Barkley has written a lot of good books on just ADHD and managing your defiant child, and just talks about parenting strategies to address these kinds of issues. And then the one for the younger kids that I almost always will recommend is Stanley Turecki's book on the difficult child. So one of the key roles is families, trying to get them hooked up with a mental health provider that can do that behavioral therapy. So licensed clinical social workers in some communities, LPCs more often are in our community down here. And then I direct families, one, to their insurance to see who's in network, or professional associations that can help, that have directories to locate those folks. The American Academy of Pediatrics has given a thumbs up to 3 specific programs that really emphasize the parent training component. So sometimes you will find therapists that have these additional certifications. So PCIT is for parent-child interaction training, okay? Triple P parenting is a big one. When I left North Carolina, it's expanded. It's been there over 10 years and is now practiced statewide. Incredible Years was developed out of Florida, so you will find some LPCs that are trained. In Texas, we've got a few pockets of Triple P. I know San Antonio has a few, some providers in the Dallas-Fort Worth area, some in Houston. And for us, the health plan is definitely trying to bring the Triple P, and right now they're sponsoring training on LPCs to develop a network of them that we can refer our families to them to receive the right kind of behavioral therapy. And when COVID happened, I mean, there are a lot of LPCs in private practice that were not set up to do Zoom. So we encourage families to check out the Triple P Parenting online program. This is evidence-based to be very effective, 35 years of research to back it up, and it was originally developed out of Australia. It's been the first online parenting program that's proven to work, and they have 2 modules. One for the toddler to tweens, and the other is preteens to teens. And when I tell families, if you do this program, there are 8 one-hour online modules, and it's all about the emphasis on positive behavioral supports to help manage those disruptive behaviors, kind of phase out maladaptive ones and promote the good behaviors of those desired outcomes. So this is one that with the pandemic, we kind of encouraged a lot. And the health plan for Driscoll is actually trying to make it a perk to cover the $80 enrollment fee for some of our families, particularly since we're about 80% Medicaid, okay? What about role of medication for some of this disruptive aggressive behavior? And that sometimes, parents are asking that. I certainly, as a specialist, try to be judicious in the use of medication and really emphasize the role of therapy first. The key is to figure out what is the context of what's happening in that behavior. If I'm really dealing with an ADHD kind of kiddo, then yes, I'm going to have a lot of poor impulse control in the mix. So it makes sense to consider medication that can rein in that impulsiveness and diminish some of that frequency and intensity of those outbursts. Other kids may be very hot-tempered and, when I say emotionally reactive, so sometimes there are other medications that can help calm that fight-flee response, okay? Some kids may have very strong mood issues going on. Perhaps they have a genetic loading for a lot of mood disorders in the family, including bipolar, so it can be the case where we might have to consider mood stabilizers to kind of reduce some of that emotional roller coaster that's going on. And lastly, sometimes we figure out that explosive behavior is actually occurring due to very intense anxiety. Very young kids can have significant generalized anxiety and lash out. The kids with social anxiety too, who's ever closest to them is going to get a whack and get hit when they're very overwhelmed and erupt in an outburst. And so those kids, we would have to think about whether an SSRI, which is an anti-anxiety medication in this particular case, would be more appropriate, okay? But that's typically not where we start first. We really encourage the psychosocial interventions first. And there's definitely a high cost if you leave this all untreated. I mean, we talk about leading to substance abuse, violent behaviors, the victimization, incarceration, and even premature death. So statistically, I know suicide is the second highest cause for mortality in our teens. The next cause is homicide, okay? That's number 3, okay? So according to a lot of the latest research, we estimate a good 50 to 75% of those youth that go through the juvenile justice system could be diagnosed with some mental health condition, okay? All right, okay. Lastly, I'm going to hit the last 2 final mood issues. We're going to do anxiety and we're going to do the depression. So anxiety, we've seen a lot. I mean, sometimes it's overt and you can tell the moment that kiddo comes into our room and they're very scared, always seeking reassurance. And we try and tease it out when we're talking to the families, what kind? Because there's different kinds. I mean, you can be that super clingy toddler and we would expect some separation anxiety, be unusual to be a little bit older and still having it. Sometimes there is a bimodal presentation, so you might see it again around 8 or 9 years of age. Other kids may have developed those specific phobias where they're like super scared and freak out mode with the dogs, insects, bugs, spiders, that kind of condition, or even just going to the doctor and seeing the white coat, that just can set some of these kids off. Being very afraid of school, not liking crowded places, hating to go to birthday parties, don't like to stand up in front of the class and give a presentation. I mean, those kids may have elements of a social anxiety, okay? And then we got the worry ward kid, the one that's worried about everything and anything. What's the test that's coming up? The news story about the thunderstorm that's 300 miles away. I mean, they're seriously concerned about it. And those kids can have that general anxiety. Then we have those that can develop panic disorder. This is more common in the adolescent, very rare in the younger kid. But they will have those somatic symptoms of heart racing, the chest pounding, and start to have the sweaty palms, and they're very overwhelmed. Okay, so identifying anxiety in some kids is just irritability and anger. Others can have a lot of somatic complaints, so they end up seeing all sorts of specialists, the GI specialist first, shortness of breath, they see pulmonology, they might see cardiologists before they figure out, this might be all physical manifestations of this kid's deep anxiety that's going on. And other kids keep to themselves. I mean, there are kids that internalize a lot of it and don't show out and exhibit those symptoms. Luckily, we've got tools. So the pediatrician can get the scared. I mean, even parents can download these and fill them out and take them to the pediatrician so they can be scored and assessed and then get better guidance of what to do next, because these do help identify what's the pattern of the anxiety and what's the degree of intensity, like the symptom severity. So you can get a better guide of what would be the next step. There's certain things you do for mild anxiety, moving on to more formal cognitive behavior therapy for the more moderate to severe, and then really reserving medication management for the kids that have the more severe impairment. Anxiety in adolescents already goes up, and post-COVID, it went up even higher, okay? So in looking at just the adolescent age group, 13 to 18, we're already at 31% prevalence rate for an anxiety disorder. And out of that bunch, it's 8.3 that we're coming out with very severe impairment. Typically, those youngsters are going to need medication management along with cognitive behavior therapy. It does differ in gender. So females tend to have more of the anxiety disorders than the males, okay? And with the post-COVID, it's definitely gone up. I did see a 13-year-old yesterday that, always had little OCD tendencies when she was younger, but it never got out of control until COVID. That poor adolescent has a lot of grooming and hygiene rituals. So she's taking 2-hour showers. She's excessively washing hands, and she's got all this chafing and dry skin all the way up to their elbows for excessive cleaning. And, you know, she's very germ phobic. So that has really taken a toll on family living. And so we had to address it and decided that we needed, at this point, given the degree of impairment, have to treat medically. Here's a list of books on anxiety management that I share with you. These are books that a psychology friend of mine have given me, and I've never lost this list because it's about a good 10 years old now. There are books written for adults, and then there's some good books for little kids too. So the older children, 7 and up, I definitely encourage, understanding their anxiety. So there's some good books there, and then even a little stress management workbook for the adolescent. All right. And switching gears with depression, okay? So we kind of identify that, look, I mean, if this comes into clinic, I'm definitely going to worry. This kid seems a little bit withdrawn. They seem sad. And again, the school teachers can be really sharp in picking up some of these changes. We worry if there's that persistent sadness and hopelessness because there may be an underlying diagnosis of depression going on. So other things that you would take notice of, the kids lose interest in the stuff that you used to enjoy. That's worrisome. In medical terms, we call that anhedonia. Changes in eating patterns can go either way. Either they're eating a lot more and gaining weight, or they're eating a lot less, okay? Changes in sleep patterns, eating, again, either sleeping more than usual or are a lot less than their usual baseline. And a lot of changes in energy. If they're really profoundly depressed, a lot of times they're just tired, sluggish. They have that psychomotor retardation. They start to have cognitive dysfunction, especially those older kids too with school. They have a hard time paying attention, a lot of indecisiveness that goes on, and then these feelings of worthlessness and feeling guilty. Girls in particular may start to do self-destructive behavior and self-injury. So the cutters, okay, those are what you worry about in the adolescent. Those that are cutters tend to be more often female. So the overall prevalence rate for children with depression is at a 0.4 to a 4.6. So it's not a big number. And unfortunately, we don't have a good screening instrument for the younger kids. They've looked into that, and they just aren't out there to justify doing one routinely. However, there is a standard recommendation for screening kids that are 12 and up. So for the adolescent age group, you definitely have a screening tool available. So if the pediatrician has a concern about a primary mood disorder in a depressed young child, I would recommend psychiatry, see them to tease that out, or a psychologist so they can do further assessment. Because sometimes the only complaint is anger and irritability, but that's very generic. So you really have to dig it out because it can be any of these different diagnoses, and you're trying to get to what that cause is for that mood disturbance happening. So the PHQ-9 is the screener that pediatricians are able to use. It's a 9-item depression inventory, and it has very good sensitivity and specificity. So if you're getting scores at 10 or above, that's an automatic referral to a mental health provider. If they're way up here in the 20 and they have active suicide ideation, that might even be a psychiatric emergency where they need to go be seen at the ER, okay? Nope. Okay. So depression in adolescents, there are some key risk factors. And so these are the things that we keep in mind when we, especially from my end, when I provide consultation. But, families, if you've got a strong family history of depression, you need to maintain that surveillance. Kids that are in the foster care system that have had histories of child abuse and neglect, definitely. A lot of these kids may have PTSD eventually, and PTSD itself as a diagnosis places these kids at 19 times higher rates of suicide ideation and attempts. So that's pretty important. Stressful life events. So, I've discovered sometimes families didn't really disclose that they were going through financial hardship till we start talking about it. They're on the verge of getting evicted. I've had one family that, due to domestic violence situation, they were now moved out of the house and moved into a home. Mom hadn't checked into a shelter. So sometimes stuff comes up like that. Kids with chronic illness. This is another population, and it becomes very relevant to a hospital like ours at Driscoll's because we got a lot of specialists that follow a lot of chronic care needs. So these kids that have renal transplant, the kids that are cancer patients receiving treatments, we've got the rheumatologist that follows those kids with juvenile rheumatoid arthritis, or the kids that have lupus, and even pulmonology, the adolescents that have cystic fibrosis, a lot of those are at increased risk for depression. And research has shown that these kids with chronic conditions, about 90% of them will have a depressive disorder. Alcohol use in adolescents not as high, but female gender, this is where it does parcel out between male and female. So the females definitely have a higher risk. The good thing is that there is full remission in a good 93% of the time, okay? So they really need to get help, whether it's cognitive-based behavior therapy for those kids that are old enough to do that, along with medication management. And, you know, sometimes parents want to poo-poo the meds, but let me tell you, they can make a world of difference and have better recovery. And sometimes even protective, because the risk factors for recurrence is definitely high, and within 4 years, they'll have a 40% recurrence, okay? All right. Recognizing psychiatric emergencies. So the youngster that may present to the school or at home that becomes violent and agitated, that seems confused. There can be acute psychosis, sometimes due to medication management, other organic medical condition, or part of a mental illness. Kids with acute anxiety where they're having severe panic attacks. And lastly, that suicidal patient. So these would constitute some psychiatric emergencies. Okay, so recognizing possible signs of suicide. So verbal threats about talking about killing themselves. And I hope that if, you know, a peer overheard a conversation like that, they would be forthcoming and tell an adult of these concerns that they may have, that their friend is talking about hurting themselves. If they're looking for ways to procure weapons, collecting pills, you know, families that already have mental health issues, parents may need to be careful where they keep their medications, and to limit access to them, and that of firearms as well, making sure that those are put away and locked up safely. Writing about death, dying, or suicide, if they're doing this and it's really going out of their way, a lot of morbid thought and thinking, that needs to be a concern. And then giving things away, because they're not going to take them with them, and they start giving their priceless collection of something that they've taken years to put together, you know, things like that would be a concern. And then the girls that are self-cutting and self-harm, okay? So I know that mental health and intellectual disabilities at MHID agencies pretty much are in every county. Ours has the list of their crisis hotline numbers, the youth mental health services. Kids that have disabilities are going to be in a different department. And if you've got any inquiries, you know, you have the different numbers. So always, you know, maintaining, hopefully pediatricians have this information for their particular county and have the local community resources kind of on a quick dial or a list that they can provide to their families. NAMI also has some chapters. I know Corpus does have a local chapter. So they put together parent work groups and discussions. Now with COVID, I'm not sure how they're doing it, but I know they were using, at least here, they had some monthly meetings in one of the agencies that does behavioral therapy, and that was a good resource. And they have a crisis helpline as well. So definitely check into your own community for having some of these resources. And one of the campaigns from NAMI is about really ending the stigma that, you know, and just, we need to just talk about it. So I'm one of those providers that won't shy away from these difficult topics, just, you know, this discussions with the families. And I say, look, we need to put all our cards on the table, kind of lay it out. This is what the evidence show. I know you're not appreciating these kinds of difficulties. And that sometimes takes a little bit more convincing to parents when you've got some adolescents that internalize a lot of it. And so their own responses on rating scales and some of these depression inventories or anxiety are super high compared to the parent that hadn't yet appreciated. But I will put more weight on what that youngster is telling me. And oftentimes we separate them from the parent for the interview and discover, you know, some of the underlying stressors for these families. All right. Okay. So that is it. All right. Let me see if I can end that.
Thank you so much. That was awesome.
Okay.
Such a difficult subject to always have to talk about, but
Yeah.
I'm so glad we have great physicians like yourself to help guide our parents around and us. And, you know, it really is important to see, if you see something, say something, because you just never know what that child is going through or anything. So we'd hate to think that any of this happens in the real world, but it does, and it's, you know, very real. So thank you so much for this information. It was very, very helpful. Anybody have questions real quick for Dr. Gulbronson?
I have one question. What do you do with those children who don't have a good family? When the families don't take the time to take them to a pediatrician or don't get the help. What happens to those kids? I mean,
And this is where schools really factored in, because if the
Okay.
schools have reported some of those families for neglect, and they've had to be forced to bring them in to the care team because they identified something was going on. And so the rates, I know my colleagues in child abuse have seen some of those rates go up, and there was more increased rates of substance abuse about these same parents, increased rates of neglect. They were seeing it all last summer. They were kept busy. And so this is where I'm hoping that, gosh, those kids need protection because
Yeah.
the parents aren't doing them right. And that's where the schools are huge in playing a role, because they see this kid day in, day out, and they get worried enough to pick up the phone and call. Otherwise, they won't show up at the doctor's office. Okay.
Mhm.
And nobody's going to be none the wiser what's going on. So it's just.
So what happens during COVID when these poor kids aren't going to school and they're in abusive households?
It's
We've heard that child abuse has gone up over COVID.
So it becomes to the point that someone in that house injured that child. Unfortunately, it's where the child was sufficiently injured to cause somebody to call EMS, activate it, and then they come with a non-accidental, the mechanism that the parent is reporting as in matching, launches an investigation to the point where they're going to be removed from the home. So it comes from something bad happening where they're finally moving to do something about it.
That's so sad.
It is. That's the
Well, that's one of the reasons we opened up in October for face-to-face learning for our certain population groups. The families are having mental health issues too. These single parents who can't work because their kids are home trying to learn virtually are struggling economically and mentally as well. So our district opened up in October for face-to-face learning for those who wanted it. We have both.
Yes.
And it was to protect our kids.
Yeah. And I strongly encourage, like, the parents that have the special needs. I'm like, look, I'm an MD, I'm a specialist, but yet I don't know how to teach a special needs kids, you know, nor have the patience. So I am really going to lean on the school to do that. So these families that have been antsy about it, I'm like, no, please get them back in school. Please get them back in school, you know, and just do that, because it takes a load off the stress. I mean, when all the schools shut down, I'm glad mine were in high school and driving, because I was not able to, I had to work. I cannot be home. So, you know, they're going to have to take care of it, you know, so yeah.
Well, and the bottom line is we've discovered through contact tracing that the COVID rates that we see are not being caught at school.
Yes.
I mean, we're practicing face masks, social distancing. Those COVID infections are being caught outside of the classroom.
And that was,
so they're actually safer at school.
They're safer at school. And this is where correcting the impression and what's out there in the media, it becomes important, because I was telling them, no, the prevalence rates of this is much lower in the younger kids. They're really not the big spreaders. Honestly, they're not. It's all the older people, you know. So we had to correct some of that because they had this incorrect information, and they were not putting their kid in school for those fears. So they needed some, you know, updated data on that.
I don't suppose you would be willing to share your PowerPoint. I would love to show that to the head of our counseling department.
Oh, sure. Yeah, that's fine.
That would be awesome.
And I emailed, so they've got it. So I emailed it, so they can always forward that to you, unless you give me your contact number, and then I'll email it to you as well. So that's.
We also record the program, Mia, so that we'll
Oops.
put this program up on our website. And so you'll have the program up there recorded as well. So if you want to
Okay,
share
great.
All right.
so much. This is, again, very, very helpful and very insightful. I really appreciate it. Just a few announcements before we go. I know we have a small crowd here, but just remember that AllMed and TextMed is coming up. May 13th is the AllMed for the Alliance. And so please go to textmedalliance.org to register, as well as go ahead and register for the TextMed as well. It's going to be virtual events, and it's going to be a lot of fun. We also are taking, at the AllMed meeting, we'll have a nominating committee to form. So we are asking you to please send in your nominations for the nominating committee. We would really appreciate that. And just, it's at the website as well. And you can just nominate somebody from your county that would like to serve on this to help elect the 2022 board. So we will not be having an ERISA series in May due to the AllMed meeting. So please plan to attend the business meeting, and we hope to see you there. That's all I have for today. Anything else, Pam?
No, you covered it. Thank you. And that's going to be the annual business meetings, 2 hours. So that's our big annual business meeting. So please invite all your members. Everybody's invited, and you have up to 10 members for vote. So be sure you've got 10 members there who can vote on the bylaws and other things we're doing. But thank you everybody for attending today. It was great to see you, and hope to see you at the annual business meeting. And thank you for the presentation. It was very,
Very
good.
helpful.
Good.
Thank you.
Thank you. Bye-bye.
Dense and rich.
Yeah.
Amazing information.
Well, thank you again for your time. We appreciate it. Everybody have a great afternoon.
Thanks.
Bye-bye.
Bye-bye.
Thank you.
Good to see you.
Bye.
And you guys have a great, oh,